Thank you.
Thank you very much, Francesco, for this. It doesn't work, for this kind introduction. It doesn't work. I'm sorry. Where do I have to? No, it doesn't work.
Shoot the presentation. Okay.
Okay.
It stuck.
Okay, thank you very much indeed. Well, ladies and gentlemen, there's a broad spectrum of retroperitoneal masses that can be classified on the basis of their origin and cell of origin, as you can see on this table, or on their distribution, or on their imaging findings. Because the treatment options vary, it is useful to be able to differentiate these masses by using imaging criteria so that an imaging pattern-based approach may facilitate diagnosis and optimal treatment management. Diagnostic challenges are numerous. They include, first, precise localization of the lesion, which may be either a primary retroperitoneal mass or a mass arising from a retroperitoneal organ, such as the kidneys, the adrenals, or the major retroperitoneal vessels or the pancreas. In this course, we'll focus on primary retroperitoneal lesions. Diagnostic challenges also include characterization of the specific pathologic type of the lesion by using anatomic and imaging criteria, and third, pre-therapeutic determination of the extent of disease. CT and MR are useful for characterization. They should include unenhanced and dynamic contrast-enhanced images and delayed phased images that are essential to characterize a fibrous and a mixed component. CT is best for assessing calcifications, while MRI has superior tissue contrast, and both have 2D and multiplanar capabilities that are useful for the assessment of the extent of disease. And other imaging modalities have a more limited role. So I have a question for you. This is the CT examination of a patient with back pain. Which of the following is true? A, this image is normal. B, a retroperitoneal mass is suspected on the right side. C, a retroperitoneal mass is suspected on the left side. D, there is no need to inject IV contrast. And E, the psoas muscles have a symmetrical aspect. Please vote now. So may we have the results, please? So that's true. That's the correct answer. That was a retroperitoneal mass on the left side, which proved to be a retroperitoneal liposarcoma. It slightly compressed the left psoas muscle, and so the psoas muscles had an asymmetrical aspect. And there was a need to inject IV contrast to better characterize the solid component of the mass. So the first step in characterization is to confirm that the mass arises from the retroperitoneal space. And anterior displacement of the retroperitoneal organs, such as the kidneys, the adrenals, or the pancreas, strongly suggests a primary retroperitoneal mass, as in this example on the left side of leiomyosarcoma, which displaces the kidney anteriorly. Let's say a few words about sarcomas. They constitute only 1% of all cancers, but they are usually huge, and 50% of them measure more than 10 centimeters at diagnosis, as is in this example, a huge liposarcoma, which compresses the psoas muscles and displaces the bowel loops towards the left part of the abdomen. And this huge liposarcoma displaced the kidney upward and anteriorly, and you can see the liposarcoma. So, second question, which of the following signs is not indicative of a primary retroperitoneal tumor? A, anterior displacement of retroperitoneal organs or vessels. B, presence of prominent retroperitoneal feeding arteries. C, crescentic deformation of the IVC. D, distortion of the renal parenchyma into a beaked configuration. And E, rounded edges of adjacent solid retroperitoneal organs, such as the kidneys. Please vote. Well, maybe we could have the results, please. Well, the correct answer, the majority of you didn't give the correct answer, was distortion of the renal parenchyma into a beaked configuration. Well, when an adjacent organ is distorted into a beaked configuration, as in these examples of renal cyst, with a beak deformation of the renal parenchyma, or as in this example of renal cell carcinoma, it is likely that the tumor rises from this organ and is not a primary retroperitoneal tumor. On the other hand, when a tumor arises from an organ, this organ may be embedded by the tumor, as in this example of primary leiomyosarcoma of the IVC. On the contrary, when a tumor compresses an organ, this organ may be distorted into a crescentic shape. Other signs might be useful. When a huge mass develops in a small organ, then this organ may become undetectable. This is the phantom organ sign, as you can see here in this example of huge adrenal carcinoma. The adrenal gland was no more visible. In addition, the presence of prominent retroperitoneal feeding artery is also a strong argument for a retroperitoneal mass. In this patient, the origin of the mass is questionable. Is it a renal mass with perionic extension, or is it a primary retroperitoneal mass? Well, you can see that the renal parenchyma is slightly compressed by the mass, which happened to be a leiomyoma of the renal capsule. Distinction between a retroperitoneal liposarcoma from an angiomyolipoma is important in terms of prognosis and therapeutic options. An angiomyolipoma requiring only limited surgery, or abstention, and liposarcoma extensive surgery. An angiomyolipoma may have a perirenal extension. Both lesions have a fatty component. However, the presence of dysplastic vessels and renal parenchymal defect at the site of origin of the mass, as you can see here in this example, also known as the cortical sign, favors renal origin, as in this patient with an angiomyolipoma, which is different from that patient with a primary liposarcoma. Although there is substantial overlap of imaging findings, some imaging features, along with demographic clinical findings, and may suggest a specific diagnosis. And we move on now to the third step of diagnosis, that is diagnostic clues for characterization. Some tumors develop in the retroperitoneal space without marked compression nor involvement of the adjacent organ, and these lesions include perirenal lymphomas, as in this example, with lesions, with bilateral lesions, irregular margins. They can be associated with renal nodules, with renal locations. They also include cystic lymphangiomas, as in this example, which may cross compartments, and you can see that there is no significant compression of the adjacent organs. In addition, some neurogenic tumors, such as paragangliomas and ganglioneuromas, extend along the sympathetic chain and have a characteristic elongated shape. I'll show you an example of multiple plexiform neurofibromas in the paraspinal regions in a patient with neurofibromatosis. It is important to detect specific components that allow to narrow the differential diagnosis. They include the detection of fat, of calcifications, of a cystic, of a myxoid or a fibrous component, and the assessment of the degree of vascularity of the lesions. A fatty component may be seen in numerous lesions, including benign lipomas, myelipomas, and angiomyelipomas, but also malignant liposarcomas, and more rarely neurogenic tumors and other tumors that are listed here. It's usually easy to identify a fatty component with negative CT densities, as in this example, and high signal intensity on T1 weighted MR images, which decrease with fat saturation. These are examples of well-differentiated liposarcomas with evident fatty component, and here with a very limited fatty component. So I have a question regarding liposarcoma. Which of the following statements is not true? A, they are the most common primary retroperitoneal sarcomas. B, they are most common in the 50-70-year age group. C, calcification is a sign of good prognosis. D, predominantly fatty liposarcomas with a minimal soft tissue components are likely to be low grade. And E, they're usually large. Please vote. Well, maybe we could have the results. Well, you're right. The majority of you are right. The right answer is C. Calcification is not a sign of good prognosis. It's important to differentiate lipomas, which are benign tumors, which require only a limited resection, and well-differentiated liposarcomas. Lipomas, which are rare tumors, are either homogeneously fatty, as in this example of lipoma, or have septa that do not enhance. On the other hand, liposarcomas, which are the most common retroperitoneal sarcomas, may have irregular septa with nodularity, as in this example, which enhance. It's also important to differentiate a high from a low-grade liposarcoma. Low-grade liposarcomas are predominantly fatty masses with poor connective tissues, while high-grade liposarcomas are heterogeneous tumors with fatty areas, but also solid components. As you can see here, the solid component and the mainly fatty component with septa that enhance. Calcifications have a negative impact on survival, and surgery of liposarcoma is usually indicated for both primary and recurrent tumors. This is a case of poorly differentiated liposarcoma, which was revealed by bilateral pulmonary embolism. You can see here that the mass was huge with only minimal fat, large areas of necrosis, and the mass extended into the renal vein and the proximal IVC. This is the operative specimen. You can see that the kidney was displaced but not infiltrated, and that the tumor had only minimal fatty component but large areas of necrosis and hemorrhage. We move on now to the myxoid stroma. Which of the following statements is not true? A, it is rich in acid mucopolysaccharides. B, it has early enhancement. C, it appears hyper-intense on T2 weighted images. D, it can be seen in neurogenic tumors. E, it can be seen in benign tumors. Please vote. Oh, sorry. Okay. Well, maybe we could have the results. Yes, you're right. The correct answer was B. A myxoid component does not show early enhancement. It is rich in mucopolysaccharides. It's rich in water. It has usually, a hyper signal intensity on T2 weighted images, but On the contrary, from cyst, it shows a delayed and low enhancement after injection. A myxoid component may be seen in numerous tumors, including neurogenic tumors, but also myxoid liposarcomas, histiocytomas, and more rare tumors that are listed here. This is an example of a leiomyoma with a fibrous and a myxoid component, and you can see the progressive enhancement on the delayed phase images, a slow and progressive enhancement. A hypervascular component may be seen mainly in paragangliomas, hemangiopericytomas, and malignant histiocytomas. This is an example of paraganglioma, which clearly appears hypervascular with dilated vessels. And you can see that CT nicely demonstrated its relationships with the renal vessels that were not invaded. I have a question for you. Which of the following is the most likely diagnosis? It's this patient who was a 42-year-old patient with a headache and hypertension. A, lymphoma. B, nerve sheath tumor. C, paraganglioma. D, ganglioneuroma. E, metastasis. Please vote. Could we have the results, please? Yes, okay. This was the illustration of what we had said, and the mass was clearly hypervascularized. Lymphomas are usually hypovascularized with other lymph nodes. There were clinical findings that were evocating paraganglioma. A fibrous component may be seen in numerous tumors, mainly neurogenic tumors, but also desmoid tumors, leiomyosarcomas, and other more rare tumors. They usually show hyposignal intensity on T1 weighted images and a heterogeneous appearance on T2 weighted images and a delayed enhancement, as you can see here. Leiomyosarcomas may have a fibrous component, as in this example, of primary IVC leiomyosarcomas with multiple areas of fibrous tissue. Calcifications are really non-specific. They can be seen in a variety of tumors. They can be seen in teratomas, as in on the tumor on the left, or also in malignant histiocytomas and in metastases in adrenal metastases from osteosarcomas, as in this example. We move now to cystic masses. Which of the following statements is not true? A unilocular midline presacral cyst is likely to be an epidermoid cyst. B, a cyst in the subdiaphragmatic space is likely to be a bronchogenic cyst. C, myxoid liposarcomas never have a cystic appearance. D, a cyst with a negative attenuation is likely to be a lymphocele. And E, urinomas usually show slow and progressive enhancement. Please vote. Could we have the results, please? Well, the majority of you gave the right answer. There is a myxoid form of liposarcoma. Let's now move on to the cystic component. They can be classified into neoplastic masses and non-neoplastic masses. Masses with a cystic component mainly include lymphangiomas, as in this example, which represent 1% of retroperitoneal tumors, which usually have thin wall and they might be calcified. They also include mucinous tumors and teratomas, both in children and in adults, as in this example, with calcification. They also include necrotic tumors, mainly high-grade sarcomas and leiomyosarcomas, as in this example. More rarely, they include bronchogenic epidermoid tailgut cysts. Non-neoplastic lesions include pancreatic pseudocysts with elevated amylase levels, and non-pancreatic pseudocysts, usually with thick walls, as in this example. They also include lymphocytes after renal transplantation, urinomas, mainly after trauma, or hematomas. Let's focus on neurogenic tumors. They represent 10 to 20% of retroperitoneal tumors. They usually affect a younger age group and have a better prognosis. They include a variety of histologic types, and most of them develop along the sympathetic ganglia, but also the adrenal medulla, the organ of Zucker-Kandel, and rarely the urinary bladder. And these are examples of multiple neurofibromas in a patient with neurofibromatosis, and you can see these lesions with a cystic component. This slide summarizes the main diagnostic clues with the detection of fat, of tumor necrosis, of a myxoid stroma, and of a cystic component. You can see the main differential diagnoses of these masses. And this slide summarizes the diagnostic clues regarding vascularity. Hypervascular tumors are mainly paragangliomas, hemangiopericytomas, and malignant histiocytomas. Hypovascular tumors are either low-grade liposarcomas, lymphomas, or many benign tumors, while moderately hypervascular tumors are mainly myxoid, malignant fibrohistiocytomas, leiomyosarcomas, and many sarcomas. A question for you. This is a patient who complains of lower extremity bone pain. What is your provisional diagnosis? Is it A, a lymphoma, B, Erdem-Chester disease, C, bone and perirenal metastases, D, retroperitoneal fibrosis, E, bone infection and perirenal abscesses? Please vote. The results, please. So it wasn't such an easy question. I mean, the renal lesions could have been interpreted as perirenal lymphoma, although perirenal lymphoma usually is more irregular and heterogeneous, but the association with sclerotic, could I have my image please, with bone sclerotic lesions and thickening of the cortex is really evocative of Erdem-Chester disease, which is a systemic non-language cell histiocytosis, which is included in the differential diagnosis of right-like soft tissue lesions, and which can be associated with lesions of the central nervous system, lungs, skin, or heart. Right-like soft tissue masses also include lymphoma, as in these examples, with kidney involvement, with compression of the renal vessels, and rarely with areas of necrosis. They also include retroperitoneal fibrosis with many different causes. It is a retroperitoneal disease, but it does not displace the aorta and the IVC anteriorly. It may show enhancement in the active stages of the disease. Sorry, and the ADC of chronic retroperitoneal fibrosis may be superior to that observed in active or malignant retroperitoneal fibrosis. Multiple soft tissue masses, as in this example, you can see here 2 lesions, may suggest retroperitoneal metastases or hematologic diseases. A preoperative biopsy is usually technically easy. I'm sorry. The masses are huge. It might be useful to differentiate a lymphoma from lymph node metastases, but it does not establish the grade of sarcomas, and it's important to use a retroperitoneal approach rather than a transperitoneal approach and a fine needle because of the risk of spreading. For the pre-therapeutic staging, CT and MR are very useful with 3D reconstructions. Thank you. As in this example of leiomyosarcoma, with no invasion of the renal vessels nor of the superior mesenteric artery. And the last question, this is a patient with abdominal pain. What is your diagnosis? Is it a metastatic node from burned out testicular carcinoma? Sorry. Is it a non-Hodgkin's lymphoma, a leiomyosarcoma, and other differential diagnoses? Well, you've seen the answer. This was just to illustrate the fact that the diagnosis was given with a percutaneous biopsy. It wasn't evident. But you can see that the tumor displaced the kidney posteriorly, which is not in favor of a primary retroperitoneal tumor. It was rather homogeneous, and there were no other lymph nodes that should suggest a non-Hodgkin's lymphoma. There was no area of fat, and the adrenal gland was seen above. So to conclude, there's a wide spectrum of neoplastic and not neoplastic conditions, and CT and MR are very valuable in detection and characterization. And although there is overlap of imaging features, the combination of imaging features, clinical and demographic data may help narrow the differential diagnosis. 2D and 3D CT and MR are essential in the pre-therapeutic staging to allow optimal patient management, which certainly requires a multidisciplinary approach. I thank you for your attention.
Thank you very much for your lecture, very precise, useful, and you gave us some particular points for discussion. Do you have any question from the audience? Because the topic is so difficult, the tumor is so much, often similar in appearance. Nobody have doubts. Well, I have a question. It's very useful, that science that you gave us about the relationship with the adjacent organs like kidney that you show to us. But what do you think about some rare occurrence, for example, some sarcoma that arise from the renal capsule? Because in this way...
Yeah, I mean, there might be difficulties in some cases, and the diagnostic performances of these signs are not 100%. And there might be false positive results, especially using the phantom organ sign, and there might be difficulties in interpretation of these signs. Yes.
Another question could be about the particular perirenal appearance of lymphoma, Erdheim-Chester, and did you have any experience about particular form of retroperitoneal fibrosis with that appearance without the bone lesion of Erdheim-Chester disease?
Yes, I mean, Erdheim-Chester disease has very different forms. It may present as an isolated perirenal mass. Bone lesions are very frequent. They are more frequent than lung and heart and lesions. But the two most common lesions are perirenal lesions and lung and osteosclerosis of the lung, tubular bones.
Okay. Thank you. If you don't have questions, we can go on.